Hi, I'm Martha Nance. I'm the director of the Huntington's Disease Center of Excellence at Hennepin County Medical Center and also an adjunct professor of neurology at the University of Minnesota. I'm going to talk about team-based care for Huntington's disease, really emphasizing caring for patients all the way from the beginning of the disease through to the end. These are my disclosures. By way of an outline, I'm first going to describe the care-defining characteristics of Huntington's disease. We'll talk about the guiding principles and the goals of therapy that I use when I'm in clinic with patients and families. We'll talk about the role of different team members in caring for patients and families. I list a few references towards the end. And then finally, I really want to emphasize caring for patients even in the late stages of the disease. And I'll show a couple pictures of what I think success looks like in late-stage Huntington's disease. So what are the features of Huntington's disease that really define how we provide care? First of all, it's a neurologic disease. As far as we know, it basically affects the brain and the nervous system and has no direct effects on other organs in the body, the heart, the lungs, the liver. So the care is primarily going to be by somebody who is an expert in neurologic diseases. There are subparts to the neurologic disease, as you have heard from other speakers. There's a movement disorder, there's a cognitive disorder, there's a psychiatric disorder. In some locations, the management of Huntington's disease may be primarily by a psychiatrist, and in other locations it may be primarily by a neurologist. It's typically an adult onset disease, but not in the later geriatric years. The onset is often in mid-adulthood. Importantly, the disease occasionally affects people much younger, even children. About 5–10% of people with Huntington's disease have onset in the childhood years. It's a chronic disease, so people who are managing patients and families with Huntington's disease will have a long relationship with that patient. And as I get older, I find I have long relationships with families over generations. It is a degenerative disease, so it's not static. There will be a downhill course. And again, the care providers, whether they're family care providers or the medical team, need to be preparing people for the fact that things will change over time. And finally, it's the quintessential adult onset autosomal dominant genetic disease. It is a family disease in every meaning of the word. The patients cannot go through a full course with Huntington's disease without help. And those very caregivers, the family caregivers, may themselves be at a 50% risk of developing the disease. So these are some of the characteristics that I have to keep in mind as I'm seeing patients and families. My principles of care, and I'm not sure that any one of these principles is any more important than the other, so I kind of have them all equally emphasized. But actually the one at the top is the one that I really like to emphasize. There's never nothing you can do for somebody with Huntington's disease. I think patients and families are often given the impression when they go to their primary care doctor or even to a neurologist who lacks expertise in HD, patients come away with the sense that they were told there isn't anything to be done about it. There is always something you can do, and you've heard that in some of the previous talks, and we'll emphasize it again today. I really think it's important to think in terms of care from the beginning of the disease all the way through to the end. Adequate care also requires providing support for the family. They will become increasingly important in guiding the patient through the course of their disease. People need to be educated. They need to know what the disease is. They need to know what it isn't. With proper education, you can be proactive about the care. Things that happen along the course of Huntington's disease should not come as a surprise. It shouldn't come as a surprise if you're no longer able to work, or if you're no longer able to drive, or if you need 24-hour care. If you've prepared people ahead of time, they should know that these next stages are coming. And finally, nobody can do Huntington's disease alone. The patient, by definition, is going to need help somewhere along the course of their disease. Even a couple, a family, has difficulty doing this disease all by themselves. I have difficulty caring for somebody with Huntington's disease, just me, the doctor in the clinic. it really lends itself nicely to team-based care. I routinely use the Scholson-Fahn Total Functional Capacity Scale in my clinic as a way to judge where patients are along the course of their disease. I think patients and families like to have a scale that they can compare notes with other people or sort of have some measurement of where they are. Am I in the early stage? Am I stage 3? Where do you think I am? And I like the Scholson-Fahn scale because it really is a functional scale. It emphasizes things that we need to do every day. It has nothing to do with MRI scans or neurons or anything. It's based on whether you're able to work, manage money, do chores around the house, do your own activities of daily living, and then whether you're able to live at home or whether you need to be cared for in a 24-hour care setting or something in between. So you can look at the scale on the slide. Just as an example, if you're working at a regular job and succeeding, you would get a 3. If you're kind of struggling with your job, maybe barely able to stay employed or working a lesser job than you used to, that would be a 2. If you could at least do some kind of volunteer work, that would be a 1. And if you're unable to work at all, that would be a 0. And similar breakdowns for those other categories, the money, the chores, activities of daily living. And then you add up the total points. The maximum points is 13, stage 1 is 11 to 13 points, and so on. And I find this useful because certain issues come up at certain stages of the disease. As you can imagine, for a patient in stage 1 of Huntington's disease, the primary issue is going to be, are they still able to work? Are they really able to manage all the household affairs as well as they used to? By stage 4 and certainly stage 5, pretty much by definition, those are people who are requiring 24-hour support. So you can imagine that different issues come up during those stages. This is a graphic that we put into the Physician's Guide to Huntington's Disease, which is available through the Huntington's Disease Society of America on the website. This is just a graphic of a hypothetical patient followed over a lifetime. The red line on that page shows the patient's progression through that functional staging scale that I described in the previous slide. You can see then at the top there are certain issues that I refer to as life milestones and then disease milestones. So if we look farthest to the left, in this hypothetical patient, the parent was diagnosed with Huntington's disease when the patient was about 15, and that's when she first became aware of the possibility of her own risk for Huntington's disease. And at age 15, that led to a suicide gesture. And then she did okay for a while until she decided to get married, and then she wanted to have a predictive gene test. And the predictive gene test showed that she indeed was a carrier of the abnormal gene. Then a few years later, when she was in her late 20s, she had her first child. And in the throes of that, maybe it was postpartum depression, maybe in retrospect it was early symptoms of Huntington's disease, there was another suicide attempt. Shortly after the suicide attempt is when the diagnosis of HD occurred, so she was by then somewhere in her early 30s. By age 35, she was disabled from work, and about that same time, her parent, who had been diagnosed 20 years earlier, died of the disease. And then you can see the progression through into her 40s when she eventually needed 24-hour care and was placed in a long-term care facility. Importantly, the death does not always ensue within a year or two after placement in long-term care. Many of our patients live for a number of years in long-term care before death. So death finally came for this particular patient in her early 50s. And so you can see this is a disease that really plays out throughout a person's lifetime, and it's sort of punctuated by both disease milestones and life events. So this slide shows the kinds of health professionals that might be involved in an HD care team. These are the folks that we have available at our Center of Excellence. Obviously, not everyone has a Center of Excellence, but most people have access to at least some of these health professionals. So at the top, I've listed the neurologist or psychiatrist who serves as, if you want to call it this, the team leader, the physician who kind of directs the patient's care. We involve also a neuropsychologist, a psychologist, a social worker, genetic counselor, physical therapy, occupational therapy, speech therapy, dietitian, research team. And at our center, where we're a teaching hospital, we also have students, the clinic staff, the frontline staff, the nurses and aides that room the patients. And this is also an ideal disease for nurse case management. So these are the kinds of people that might be involved in the care of a patient over the course of a lifetime. What are the goals of care? Until we find a cure for Huntington's disease, the goals of care really are to reduce symptoms, to maximize function, and really the number one goal is to improve the overall quality of life. To do that, if you're really doing a good job, you are not reacting to symptoms or problems, you're actually anticipating likely problems. You're educating the patient, you're providing support for the patient and family. And then one of my personal, I don't know, for some reason I get excited about continuing care really into the late stages and avoiding abandonment of the patient in the latest stages. So just to review a little bit what these various health professionals might do during the course of a patient's life. The neurologist or psychiatrist, the medical doctor, serves as the team leader, writes prescriptions, manages medications, monitors the disease progression, identifies symptoms, initiates referrals to other members of the team, and also has a role in education and research. We're really trying to get more and more community neurologists involved, at least at a basic level, in HD research. The psychologist may play multiple roles in the management of a family with HD. There are relationship issues between the patient and other family members, grief, coping, adjustment for the patient, non-pharmacologic ways to manage some of the psychiatric symptoms such as depression, anxiety, obsessiveness. The caregivers often need support as they go through the course of the disease with the patient. And then quite often a psychologist will be involved in predictive testing to assess patients prior to a predictive gene test and to help follow up afterwards if the patient has difficulty handling the results of their predictive test. The neuropsychologist can provide a formal assessment of cognitive function, which in certain situations can be really important for the diagnosis. It certainly is often very important in assessing functioning for disability or legal purposes. For instance, patients whose jobs are primarily cognitive jobs, professional, white-collar professionals, really the disabling part of their disease may be the cognitive part, not so much the motor part. The neuropsychologist can also help us to monitor disease progression. I put that in parentheses because in the clinic I may or may not need to do formal cognitive testing to know whether the patient's cognitive function is changing. Sometimes you can simply assess that in the office with an office exam. And then the neuropsychologist is an important part of our research team. The genetic counselor takes a family history, does what we call genetic counseling, which is explaining the genetic aspects of Huntington's disease to the patient. Importantly, both the patient and other family members have a stake in understanding not only the patient's genetic risks, but what does this mean for others in the family, brothers, sisters, children, cousins. And so we often have the genetic counselor off in another room speaking with the children while the doctor is working with the patient or the wife. As you've heard in some of the previous presentations, it's possible to do predictive gene testing. The gene is present from the time of conception, so it is possible to learn even prior to symptoms whether you have the abnormal gene and will someday develop Huntington's disease or not. Whether you want to have that gene test or not is a challenging issue. In the U.S., it's probably fewer than 10% of people at risk for Huntington's disease who are asking for a predictive gene test, which means that 90% of people at risk are not asking for a predictive gene test. So it's worth talking to a patient. Why does this particular individual so much feel the need for a predictive gene test? Prenatal testing is something else that's possible, either by amniocentesis or chorionic villus sampling after pregnancy, or by pre-implantation genetic diagnosis. So the genetic counselor can be very helpful in explaining these complex array of genetic testing options and really supporting the physicians and the families in understanding this critically important part of this disease. Many people view the social worker as being the most important person on a Huntington's disease care team. Patients often come to us in crisis, so the very first thing that needs to be managed is not so much prescription for medication, but really dealing with a psychosocial crisis. Social workers can also help patients navigate or at least understand the process of disability, difficult issues around health insurance and other types of insurance, financial planning, accessing community services in later stages of the disease, day programs, Meals on Wheels, in-home services, respite care, and then also helping with nursing home placement in the later stages of the disease. Rehab therapists, physical therapy, occupational therapy, speech and language therapy may play a role off and on throughout the course of this disease. Early in the disease, patients are encouraged to have a good exercise program. Later in the disease, they may need assistive devices for gait, special seating arrangements for people with severe chorea, positioning issues, sitting in a chair, avoiding falling out of bed, may be issues for late-stage patients with very severe chorea. The occupational therapist helps, of course, with assessing safety and providing appropriate assistive devices and equipment to optimize the patient's function, either in the home setting — we'd like people to stay at home as long as possible — or in the nursing care facility. I always say that the speech pathologist and the dietitian are the most important people on my HD team. The speech language pathologist can address both issues around communication. As you know, one of the motor effects of Huntington's disease is to cause slurring of the speech and difficulty communicating. Obviously, it's those same muscles that are used to chew and swallow. And so dysphagia is a almost inevitable consequence of Huntington's disease. And in fact, I generally say that morbidity and death in Huntington's disease generally has to do with dysphagia. So early monitoring for dysphagia, using compensatory strategies, perhaps later on looking at feeding tubes for appropriate patients. We often have a combined visit with the speech pathologist and the dietitian. Weight loss is very common in people with HD somewhere during the course of the disease. Sometimes the weight loss is much earlier in the disease than you would think. It's not always just a late complication. So early assessment of weight and nutritional status, counseling regarding healthy eating. When the speech pathologist does a swallow test and says something like dysphagia 2 diet, the dietitian can help to translate that into English. What foods can you eat? What foods should you avoid? And the dietitian may also be involved in working on the right types of nutritional supplements after a feeding tube placement. As I mentioned, this is a complicated disease, and so if you have availability of someone to serve as a case manager whether it's a nurse or social worker. It may be different people in different hospital settings or clinic settings. Complicated patients, complicated families, complicated healthcare delivery system, complicated social consequences of the disease. So case management can really be very helpful. It's important not to neglect general medical care during the course of this disease. The typical course plays out over 15 or 20 years. So having appropriate age-specific medical care and not neglecting that just because you have a diagnosis of Huntington's disease, this is important. I think we need to get past this fatalistic view that there's nothing you can do, so why bother? And in particular, we emphasize dental care. This is a disease that affects the ability to use the tongue and the lips and the mouth. And people with Huntington's disease may be somewhat neglectful of their own personal hygiene as the disease progresses. So really getting people early on in a program of aggressive dental care so that you avoid losing teeth on top of having trouble using your tongue and lips. Obviously, if you lose teeth, it makes eating and talking that much more difficult. I feel that research is an integral part of Huntington's disease care. It provides hope. I always tell my patients that they are uniquely qualified to help me find better treatments for Huntington's disease. I can't do it without them. They can't do it without me. Let's work on it together. It engages the patient and family in something that's positive, where this is a disease otherwise of loss after loss. There is a international, really global research registry starting up called Enroll HD. And one of the goals of Enroll HD is to really engage as many patients and family members and researchers, including community neurologists who maybe see 5 or 8 or 10 people with Huntington's disease. Possibly even those community-based neurologists can get involved as investigators in the Enroll HD study. I think it's important to recognize the role of spiritual health in improving quality of life for patients and families, whether you have a chaplain in your hospital setting or whether you simply encourage patients to pursue their own spiritual health and faith communities. I think this is a critical part of good quality of life. Nursing home staff help us to provide continuing care to the very end. Nursing home staff need to understand about Huntington's disease so that they can provide good care. There are a few locations around the country where there are nursing homes that have a specialty unit for people specifically with Huntington's disease. And some patients thrive in an HD specialty unit. Say a place where there are 20 or 30 other people with Huntington's disease. Other patients with Huntington's disease don't really need a specialty unit and actually do better just in their local home community facility or a group home where the community can kind of rally around the patient and the family can be nearby. We interface frequently with the local Huntington's Disease Society of America chapter. There are chapters throughout the country, and the volunteers that work with the chapters can really almost serve a physician extender or outreach role. The volunteers themselves can provide support to other people in the community. They can provide some education at times and places that I can't get to when I'm in the clinic. Working together with the lay community helps to nip any misunderstandings in the bud. It's amazing how much people still don't understand the 50-50 genetic risk, for instance. People have misunderstandings about how the disease is passed on. People have misunderstandings about what treatment works or what vitamins do or don't do. Working together with the lay organization really helps you to spread your knowledge and skills to a broader community. And I personally find that the volunteers in our Huntington's disease community in Minnesota are inspiring. And if you don't talk to them, if you don't work with them, you're really missing what your work is doing for them. It really plays back and inspires our entire medical care team. So now I'm going to show a couple slides that emphasize the involvement of health professionals throughout the course of a lifetime of somebody with Huntington's disease. So this is the same slide I showed earlier on, except there are the little blue asterisks. These would be points in time where a neurologist might come in contact with this patient over her 50-some-odd year lifespan. Remember at age 15, when the patient first became aware of her risk of Huntington's disease and had a suicide gesture, someone might have called the neurologist at that point asking, is she having symptoms of Huntington's disease? So there was a neurologic exam then. Quite often the neurologist is involved as a patient is asking for a predictive gene test to either do a neurologic exam before the gene test or to do a baseline exam after the gene test, maybe followed that patient for a little while after the gene test. And then certainly at the time of diagnosis, we routinely see patients, if they're doing okay, about every 6 months. And then that continues throughout the course of the patient's life until the very end. The speech pathologist might get involved, again, in my clinic very early on, shortly after the diagnosis. And then a year or two later, or 4 years later, as the swallowing function changes, as the communication becomes more and more impaired, the speech therapist may be re-involved. So the speech therapist then has a 15 or 20-year history of involvement with that particular patient. The genetic counselor might have gotten involved way back when the patient was 15 and became aware of her risk of Huntington's disease. We do, I love to have the teenage children of my patients come into clinic so they can really learn the facts about HD. They often have questions about their parent that they don't really want to ask the parent. They also have a growing awareness that this disease may impact on their own lives, and they need to understand, what does 50-50 mean? What does gene testing mean? Why would you have it? Why would you not have it? The genetic counselor also is really the point person in doing a predictive gene test or involvement in prenatal testing, as I mentioned earlier. And then there's a star much later in the disease when the patient is about 45 years old. Well, guess what? By the time that patient is 45 years old, her child that was born 20 years earlier is now 20 years old and needs to think about predictive testing or just understanding the risks of HD now that she herself is a grown-up. So the genetic counselor may have a relationship with a family over the generations as well. And I'm not going to go through slides for all of the other health professionals, but you can sort of think in your own mind at what points along the disease might different health professionals touch that patient or family. These are just a few references about sort of overall care for Huntington's disease. Importantly, there was a document written by the European HD Network, published in 2009, that really reviewed all the previous literature on physiotherapy or physical therapy for people with HD. There are some references on nursing, dental care, and the Physician's Guide to Huntington's Disease, which came out in 2011. That sort of provides an overview of some of the things we've talked about today. And just a couple brief comments about late-stage care. In my experience, up until even now, late-stage care for people with Huntington's typically takes place in a long-term care facility. That may be changing, I think, as we move farther into the 21st century. There's more and more of a push to get people out of care facilities and to be at home. There are reasons why this is difficult in a HD family. Because of the somewhat younger onset age, the patient who's needing 24-hour care may only be 50 years old. The spouse is still working. The spouse is trying to raise children. and trying to work, manage kids, and provide 24-hour care for a spouse can be a daunting task for anybody. And that's in contrast with the typically older age of people with Parkinson's disease or Alzheimer's disease, where the spouse is often also retired and is able to be at home with their loved one without as much disruption. So in my experience, the late-stage care usually takes place in some kind of long-term care facility, but not always. As I mentioned earlier, there are some Huntington's disease specialty units in some states in the U.S. It's important to understand that people with HD look and feel different to the long-term care facility than many others who are in long-term care. As I mentioned, the age is typically much younger than the usual community nursing home patient. The behavioral issues for some patients it can be a severe problem, and nursing homes may be reluctant to take on somebody with Huntington's disease just because they've heard that Huntington's disease causes behavioral problems, whether or not that particular patient has behavioral problems. The movement disorder is somewhat challenging in the nursing facility. We have found that our patients go through equipment, chairs, beds, toilet seats because of the involuntary movements. And later on, there's also a lack of good control of volitional movements, so that a patient trying to sit on a toilet seat may end up flinging their body onto the toilet seat, which then breaks off from the wall. So the behavior, the age, the movement disorder tend to distinguish people with Huntington's disease from other typical residents of long-term care facilities. In addition, the course in the long-term care facility may be quite long, and this is very different from Parkinson's disease, where the typical course once a Parkinson patient moves to long-term care is no more than 2 or 3 years. For our patients with Huntington's disease, it may be 5, 6, 10 years. Hospice care may be appropriate. We use hospice quite frequently for our terminal stage Huntington's patients. One of the questions that always comes up is, how do you know when someone with a progressive neurodegenerative disease has now reached the terminal stage of their disease? And that may be difficult to be 100% sure, but I think in general, if a patient is still able to walk and talk, they are probably not in the terminal stage of their disease. Conversely, a patient who is mute and non-ambulatory is certainly in the very late stage of their disease. If you add on to that weight loss or recurrent aspiration pneumonias, or some people with Huntington's disease will develop what I think in the Alzheimer's community they refer to as terminal agitation. So a patient who hasn't usually been agitated, has been pretty mild-mannered, and all of a sudden I'm hearing that the patient is screaming or flailing out or agitated in this context of somebody who's otherwise seems to be in the latest stages of their disease. That may be a clue that someone is really reaching the end. And I have found hospice care to be very helpful for me, for the patient, for the family, and also for the nursing home staff, who have often developed almost a family relationship with the patient. It's hard for them when the patient is really reaching the terminal stages as well. And my last slide just shows what I view as success in the late stage of care. On the left side is one of my dear patients who has been involved for years in one of our fundraising activities, the Hoopathon. This Hoopathon has raised hundreds of thousands of dollars for Huntington's disease research over the last 15 years. In the middle panel, you see Ivy at the nursing home doing manicures for people in the late stage of Huntington's disease. How on earth she does it, I don't know, with the movement, the chorea, and so on, but you can see the smiles on the faces of the folks who've had their manicures. And then finally, in the lower right, we actually have in Minnesota a family that set up a group home for people with Huntington's disease, and it's just a house that people live at, and their families can come visit, and there they are out on the porch. So thank you for listening, and I hope that we can all go back to our practices and really manage Huntington's disease with optimism and enthusiasm. So thank you.